So we will continue where we left off last day. These are the names of the coagulation clotting factors, coagulation factors. So, and we had discussed the coagulation pathway yesterday. What you have learnt in school, in addition to those 13, we know 13 factors. In addition to those, add high molecular weight kininogen, prekallikrein, kallikrein. This is the prekallikrein is the precursor of kallikrein, and lastly platelet phospholipids. Where prekallikrein and kallikrein are needed, in which step? High molecular weight kininogen, where these are needed? In the which pathway? Intrinsic or extrinsic? Intrinsic pathway, which involves the first factor among the first 13. Which factor is involved in starting the intrinsic pathway? Factor number 12. So, factor number 12, to activate factor number 12, first comes high molecular weight kininogen, but conversion of factor 12 to activated factor 12 by high molecular with the involvement of high molecular kininogen is slow. As soon as some activated factor 12 is formed by positive feedback mechanism, it itself along with it converts prekallikrein. Activated factor 12 converts prekallikrein to kallikrein, and kallikrein kininogen now together, this process of conversion into activated factor 12 gets accelerated. Without kallikrein, what will happen? The process can still go on, but the pace will be decreased. So, we have discussed all these and we will continue. So, I think it was, you were due to write this yesterday, you can write it again later. So, we will continue. So, this is the factors. Intrinsic pathway starts with factor 12, injury starts with, extrinsic pathway starts with factor 7, but with the involvement of tissue factor, which is also tissue factor or tissue thromboplastin factor 3. Then they form complexes, like in case of the intrinsic pathway, there is something called the Tines complex. After the factor activated 9 is formed, and 8 to 8A by thrombin, together 9A, 8A calcium plus platelet phospholipids, which is the last one in that list, constitutes the Tines complex. A similar complex correspondingly in the extrinsic pathway, that consists of factor 7, factor 3, calcium together and platelet phospholipids. Prothrombin is also, then 10A, that means activated factor 10, activated factor 5, calcium and platelet phospholipids. And thrombin is required in so many steps of blood coagulation. Okay, thrombin is, and one interesting thing is that thrombin itself can induce its formation after once it is formed, and thrombin itself, prothrombin to thrombin itself is induced by, this is also a type of, it can be said a type of positive feedback, that means it accelerates its production. So, I had in this list I had told, I had told to take down the names. I had tried to explain most terms are historical, or the proper nouns which you get are according to the individuals in which they were established, not the names of the scientists or the medical persons, in the like the patients or the individuals in which some factor was found deficient, like the Stewart-Prower factor, some Mr. Stewart, Miss Prower. I had told all these things yesterday. I had just told that I could not recall SPCA, the full form yesterday. It is serum prothrombin conversion accelerator, SPCA, serum prothrombin conversion accelerator. Again, the terms are historical. That time it was thought that prothrombin to thrombin conversion is done by 7 itself. Gradually we have come to know of this, what we know now, the pathway. Maybe this is science, this is evolving, science is always evolving. More concepts, more new concepts can come in future, but what we know now, that time it was thought factor 7 is itself converting prothrombin to thrombin. So, its one name is pro-convertin, its another name is serum prothrombin conversion accelerator, or other name is stable factor, because it is resistant to the environmental temperature, or physical characteristics are more or less stable, and physical characteristics are more or less labile in case of factor 5. So, it is called the labile factor. That labile or stable term has nothing to do with the coagulation pathway itself. All these things we had discussed. So, this is the last step, prothrombin to thrombin and formation of fibrin monomers. This also we had discussed. This is the pathway. So, today we will pass on to the topic how this, which we had already mentioned yesterday, factors which maintain blood in its fluid form, does not allow naturally blood to clot within the vessels, like what we had mentioned, these factors which were written in that blue box, this one. These are the factors which are pro-coagulants, pro-coagulant factors, thromboplastin tissue factor, von Willebrand platelet activating factor, all these things. And also inhibitor of plasminogen activator, because plasminogen activator induces plasminogen to form plasmin that leads to fibrinolysis. Now, inhibitor of this activator will ultimately be a pro-coagulant. Do you get it? Plasminogen activator induces plasmin formation from plasminogen, so that plasmin can cause fibrinolysis. Fibrinolysis is breaking down the clot. Which part of hemostasis is this? Tertiary hemostasis. Primary, secondary hemostasis is establishing the clotting. Tertiary hemostasis is breaking down the clot because the body has to maintain the balance, and this balance is called homeostasis. This is different from hemostasis. Even in this 2000, this last university exam, the first question, the first 15-mark question which you have to write, that first question is of 15 marks. It has, usually it is not like a direct 15 marks, it is divided into parts. So, in one of the parts, homeostasis was to be described, not in general, in case of, in a context of a cardiovascular system. I don't remember whether it has been still discussed or now. Factors regulating blood pressure and all these had to be written. Okay, I think it will be discussed. It has not been discussed till now. So, that is homeostasis, how the blood pressure maintained physiologically, how the body tries to bring back blood pressure to normal. So, that is homeostasis. There are students who have completely, that means misjudged it or not understood it. Instead of homeostasis, they have written about hemostasis. These are completely different terms. Okay, so instead of homeostasis, they have written about hemostasis, and obviously that was, as far as I remember, out of 15, that was of a 6-mark part. So obviously no credit can be given. Okay, so these two terms are distinct. So that is homeostasis. So this homeostasis is this internal milieu balance. So these are pro-coagulant factors. Plasmin to plasminogen is plasminogen to plasmin is induced by plasminogen activator, which again, if there is some factor which can inhibit that plasminogen activator, it is again becoming a pro-coagulant process. Pro means which is helping in coagulation, that is, it is not allowing plasminogen to break down fibrin. Okay, fibrinolyze, that is, fibrinolysis won't be possible, or it would be slowed down. So these are the natural anticoagulants. So first is endothelial derived antiplatelet substances, protein C, protein S are the natural anticoagulants. We will discuss 1 or 2 lines more about this thing. So endothelial surface. So first we talk about the endothelial surface properties which are helping in maintaining the blood in the fluid state. First is smoothness of the endothelial surface itself. Smoothness of the endothelial surface, this prevents contact activation. That means between these, all these we have talked about, this von Willebrand factor, these collagen, lamin, all come into action when the endothelium is breached. Before endothelium breach, that smooth surface does not help or does not induce this or does not bring about this clotting process. Okay, smooth surface actually prevents this clotting phenomena. So that is the first point. Next is one glycocalyx layer. Again, this glycocalyx itself, this glycocalyx layer itself repels these clotting factors and platelets, and also a protein called thrombomodulin. Just this will be mentioned in textbook, but still you can write it down. Thrombomodulin. Even if you can't write the, say your time is short, somehow your time is short in the exam, you are answering a question, even if you cannot write the, while answering a subjective question, if you can write what are marked in red here, if you can write at least the lines, how it does, even if you cannot write, some credit you will get. Smoothness of the endothelial surface, glycocalyx present on the endothelial surface, and thrombomodulin, it actually binds thrombin and does not allow thrombin to act as it should. So actually it gets bound to thrombin. So Glycocalyx layer repels, smoothness itself prevents the intrinsic clotting factors, activation of the intrinsic clotting factors, and Glycocalyx layer prevents the platelet and the clotting factors. So these are the 3 points or 3 properties or 3 points or properties. Thrombomodulin is actually not a property, it is not a physical property, it is a substance itself. So these are the properties on the endothelial surface. And what are the endothelial derived some antiplatelet substances? Antiplatelet. Thrombomodulin is not an antiplatelet substance, it is binding to thrombin. Nitric oxide, what it does, it diffuses into platelets and it forms something called CGMP. You have heard about it, I think, cyclic guanosine monophosphate. You have heard about in the general physiology classes. So CGMP formation reduces intracellular calcium concentrations. So thereby calcium is needed not only in the coagulation pathway, calcium is needed in it has so many functions in the body. Calcium is needed in platelet activation, adhesion, this platelet adhesion followed activation. Actually adhesion should be written prior to activation. The steps are adhesion, activation, then aggregation. So thus this nitric oxide is one factor that is doing antiplatelet action by the formation of CGMP, and next is PGI2, whose full name is prostacyclin. These prostaglandins, you will read about more of this. You have read in a bit in general physiology. You will read about more of this in pharmacology. Prostacyclins, so prostacyclin is a prostaglandin which is named as PGI2. So PGI2 binds to these receptors. So if you forget the receptors also, cyclic adenosine monophosphate, it induces CAMP. If CAMP is reduced, increased CAMP levels itself inhibit platelet activation. So one is nitric oxide, one is prostacyclin, PROSTACYCLIN. The full name is not mentioned there. And another enzyme which you can see, ectoadenosine diphosphate enzyme, it breaks down ADP. Platelets has ADP in their dense granules, breaks down ADP to AMP. So if there is circulating ADP is less, then platelet aggregation is inhibited. So these 3 things, these are also derived from the endothelium but acting as antiplatelet substances. Nitric oxide and then prostacyclin and ectoadenosine diphosphate enzyme. If you forget the name of the enzyme, at least try to write there is an enzyme which breaks down ADP to AMP. In subjective questions, if you forget one part, at least write whatever relevant you know. That means not irrelevant things. Don't write something which is wrong. If you forget the name, then write at least there is an enzyme which breaks down ADP to AMP. And without circulating ADP, platelet aggregation is inhibited. Right? Antithrombin III and heparin, I have made it as a separate heading. These are substances. We have spoken of thrombomodulin, we have spoken of these antiplatelets substances, endothelium derived, this enzyme 1 and this PGI2 prostacyclin. Antithrombin III is one substance which is produced by the liver and it is circulating. It is chemically it is a serine protease inhibitor. Serine protease, circulating protease inhibitor. It binds to serine proteases. So binding facilitated by heparin. Heparin is produced by, say from your knowledge of WBC classes, at least basophil and also basophilic mast cells. Mast cells are present around the connective tissue in almost, if not all cells, in most cells in the body. So heparin is produced by that. Antithrombin III itself can act. Heparin also has some anticoagulant properties, heparin itself, but that is very less. Heparin is mainly helping antithrombin III in its anticoagulant properties. So antithrombin and heparin itself has very little anticoagulant property by its own, but it helps antithrombin III in its anticoagulation properties. Heparin and another molecule. This is a related molecule, somewhat chemically different than heparin. It's called heparan sulfate. But this is somewhat paradoxical. Heparin, it's a heparin. The name heparin sulfate contains the word sulfate, but sulfur is more in heparin. This is just for knowledge, just chemical that is knowledge about this chemical characteristics. Heparin sulfate, a molecule like heparin, this also helps antithrombin 3. But sulfur portion is more in heparin than heparin sulfate, though the name contains, the name sulfate is included, word sulfate is contained in heparin sulfate. So, heparin and heparin sulfate contains, that means assists antithrombin 3, and antithrombin 3 which blocks, or it should not, the word should not be block, it inhibits which factors? That is, one comes from the name thrombin, that is activated factor 2A, which is factor 2 is prothrombin, activated factor 2 is thrombin, and also factor 8. These two are mainly inhibited, but also some factors 2 and 10, but also 9 and 11 and 12. 2 and 10 mainly, but also 9A and 12, the activated forms of them. So, if these pro-coagulant factors or the coagulation clotting factors are inhibited to some extent, then this is helping to maintain blood fluidity. Otherwise, these factors itself will lead to blood clotting within the vessels itself. So, that is antithrombin 3 is preventing that. Like one question, GI system, as I have heard from our HOD sir, that GI system is almost complete to be taught. So, one question comes, explain why type of question, pancreas is not auto-digested. So, there are reasons for it that has been discussed, I think. So, pancreas, so like that, why does blood does not clot within the vessel? They explain why type of question, reasoning questions. Blood does not clot within the blood vessels itself. So, this is just a repeat, natural anticoagulant mechanism, prostacyclin, antithrombin 3, protein C and protein S. Protein C, actually the activated form of it is required, protein C, and protein S is a cofactor of protein C. Protein C activated by, again, thrombomodulin binds to thrombin, does not allow thrombin to act, plus this thrombomodulin complex activates protein C. Okay, protein C is a factor. These proteins, again, the namings are historical. Protein C is named after some form that is from the how these were separated, first discovered. So, that way it has been named protein C. S is a cofactor, S has been named. So, there are different reasons for naming this. We can't always also remember also the reasons for such naming. So, there are so many names like this. So, some things we have to memorize. Protein C and protein S is a cofactor for protein C. These cleave down factors, these does not allow activated factor 5 and activated factor 8 to form. So, who is forming activated factor 5 and activated factor 8? Which substance? 5 to 5A, 8 to 8A by thrombin. Thrombin has so many required in so many steps. It is by thrombin. Just go back. See. So, who inhibits this? Protein C and protein S as cofactors. Thrombin so many steps, 8 to 8A, 5 to 5A, formation of thrombin itself and formation of fibrin, and also cross-linking of the fibrin, so that finally the secondary hemostasis is complete. Thrombin is required at so many steps. So, protein C and protein S interferes here, here and here. Follow the red dot, this area and this area. So, this one antithrombin, as we told, binds, inhibits thrombin, that is activated factor. Thrombin can be also written as activated factor 2, prothrombin to thrombin. Thrombin at 10A, TAT complexes mean thrombin antithrombin complexes. These are eventually removed by the liver, and the action of heparin, antithrombin, is actually increased almost or more than 1000 times by action of antithrombin is increased almost 1000 times. In some books it is written hundreds to 1000 times by thousands of folds by heparin and heparin sulfate. Heparin and heparin sulfate. More is heparin, that means more potent in this regard is heparin. There is a something called tissue factor pathway inhibitor. Again, this is also a Procoagulant property or anticoagulant property? If it is tissue factor pathway inhibitor, tissue factor is tissue thromboplastin. This is procoagulant. So pathway inhibitor. It blocks where? Again see, this is, and it has two forms. If you don't remember, still okay, but I'll still give it just for if somewhere you get MCQs like that. What are the two forms? It is not, don't write TFPI 1 and 2. It's TFPI alpha and beta. There is some distinct, that means a difference in the chemical structure. These are called some Kunitz moiety and all, forget that, but K1, K2, K3, here there is no K3, forget this, there is two forms, TF1 alpha, TFI alpha and TFI beta. Mainly what we know is it inhibits the factor 10 and factor 7 complex at the active site. Factor 10, factor 7 complex comes in which pathway? In extrinsic pathway. So it inhibits this one, including calcium. So tissue factor pathway inhibitor. But some authors are saying, most authors are saying factor 5, factor 10 complex, it is also inhibited. Tissue factor pathway inhibitor inhibits not only the factor 10, factor 7 complex, but its alpha form can also inhibit factor 5, factor 10 complex. Which is that? What is the name of that? Here. So name is tissue factor pathway inhibitor, but later it has been found the alpha form can inhibit that one as well, not the beta form. Beta form inhibits only this one. This is this site. Prothrombin thrombin, that is just for mentioning it. Here it is acting. TFPI is blocking this one, but its alpha form can also inhibit factor 5, factor 10 complex. I have just written I and E over here, that has been written by me to mention that this is the intrinsic pathway ultimately forming the factor 5, factor 10. Extrinsic pathway is forming factor 5, factor 10, and tissue factor pathway inhibitor, although the name suggests that it is something to do with the tissue factor, which it actually has. Factor 7, factor 10 plus tissue factor is also there. The tissue factor is factor 3. This complex is inhibited, but also factor 5, factor 10 by only the alpha form. So in fact, some at your level, if tough MCQs are also set, that which form inhibits which pathway and all, if there are MCQs, you can tackle it from this information. Although while writing subjective answers, if you can write this much that there is something called the tissue factor pathway inhibitor, in my opinion it's enough. But the more you know, if you can apply it, then you get more credit. Okay, like you don't have to also, if you can't remember Tinase complex and all, it is still okay for you, but at least you have to write the names of the factors which are involved in all the pathways and at which level, which steps thrombin and calcium are required. That at least you should write or answer in the viva. So this is again the same things, activated protein C to activated protein C by thrombomodulin thrombin complex. Proteinase is a cofactor. These are not allowing factor 5A, activated factor 5 or activated factor 8 to form, and activated protein C also, that again see what is tissue plasminogen activator or the plasminogen activator doing, converting plasminogen to plasmin for fibrinolysis. Now there is something called the inhibitor of tissue plasminogen activator. So that will again be a procoagulant. So plasminogen and plasmin, these are doing fibrinolysis, so going towards anticoagulation, and inhibitor of that plasminogen activator is going towards procoagulation. Again activated protein C again inactivates that inhibitor, so it is again going towards anticoagulation. Activated protein C not only inhibits the formation of activated 5 and activated 8, but also it inhibits or inactivates the inhibitor of plasminogen activator. That means just try to this will jumble up, mix up plasminogen to plasmin. So whatever plasminogen is converted to plasmin by plasminogen activator, or it is also one form of plasminogen activator is the tissue plasminogen activator, which is written as, I think, TPA. So whatever activates tissue plasminogen activator will go more towards anticoagulation. Now there is a factor called inhibitor that is not named, but inhibitor of this tissue plasminogen activator. That means plasminogen can't be converted to plasmin. That is again not, that is slowing down the fibrinolysis process. That is a pro-coagulant type of property. That is fibrinolysis. Do you get it? So don't mix it up. Plasminogen active plasmin fibrinolysis. If plasminogen cannot be converted to plasmin, then it is going towards pro-coagulation. Then that is tissue plasminogen activator will convert plasminogen to plasmin. If something inhibits tissue plasminogen activator, then fibrinolysis is being hampered, at least to some extent. Nothing in the body is not, most things in the body, that is not complete. It is not, that means it inhibits to some extent, it inhibits to a certain extent, if it inhibits to a great extent. But many things are not fully inhibited, but at least it will be slowed down or it will be hampered. Now that is inhibitor of this. If something inhibits this, that will, fibrinolysis will hamper. Again, if something is there that inactivates this inhibitor itself, then that will again help to cause fibrinolysis. Think it like that. That is what activated protein C is doing. Inactivates the inhibitor of tissue plasminogen activator. Still, if you can write, okay, but if you can write it inactivates or prevents the formation of activated factor 5 and activated factor 8, that is sufficient. In addition, it inactivates the inhibitor of tissue plasminogen activator. These are again these anticoagulant factors just summarized. Tissue factor pathway inhibitor, antithrombin III, thrombomodulin as a cofactor, that means thrombomodulin binds to thrombin, activates the protein C and itself does not allow thrombin to act. Protein C, protein CA is activated protein C, protein S is the cofactor for protein C. Plasminogen activators are actually of two types. If you want to write it down, it is tissue type, another is urokinase type plasminogen activator. And urokinase type, I think so details are not required for you, but still these are the days of MCQ, so I go on mentioning some details. Plasminogen activator, mostly it is tissue type, but it is another type is called urokinase type, which again requires a receptor to be bound to the, that means to act. That is urokinase type plasminogen activator, receptor, plasminogen, plasmin I have talked about, and the last three are not actually anticoagulants. Those are again plasminogen activator inhibitors 1 and 2. So that can be said as these are mentioned in the table because these are it is inhibiting alpha 2 antiplasmin, inhibiting plasmin. Okay, one form is alpha 2. So these last three are not anticoagulants actually. These are plasminogen activator inhibitor, plasminogen activator inhibitor 2, alpha 2 antiplasmin. If you can't remember so much, at least remember the names plasminogen and plasmin. And among the forms of plasminogen activator, mainly we talk about TPA, tissue type plasminogen activator. There is an inhibitor for it, and activated protein C inactivates even that inhibitor. Okay. So this is about some, this was about some how the blood is maintained in fluid form or how fibrinolysis is occurring, tertiary hemostasis, and why does not blood. If you have to explain, if it is a reasoning type of question, it will be for just this time for just a exam which happened in October, November 25, it has changed. Explain why type of question was previously I think for 4 marks or 5 marks, and now it is for 5, and there are some questions for 6 marks now, that is clinical. This time they have changed, it was just proposed in June 2025. So there are some 6 marks question which is on clinical, some clinical aspects. Clinical aspects, clinical applications of different topics. Okay, like say you are asked to write about say something about say hemophilia. So hemophilia is that means clinical application of this topic, hemostasis and all. So 3 6 marks questions will be there. Earlier last year, that means the up to the previous university exam, last university exam first prof was in October November 2025 for this university. Till the last one there were 2 15 marks questions and 10 MCQs, and the rest was like they explain why. Now it is 1 15 mark question, 12 MCQs, but the rest 13 marks which are divided into the short notes and all. So those are clinical short notes, 6 marks, and some there are direct short notes of 5 marks. There are I think 8 of them or so, so 40 marks. So I'll tell you about it. We are ourselves getting acquainted. These have just come newly. Only one university exam has been held in this format. 1 15 mark question, 12 MCQs and all. Blood clotting disorders they have just mentioned in the, if you go through the CBME, yesterday I had also mentioned bleeding and clotting measure and just discuss briefly. This is a topic which you will extensively read in I think medicine when you go to the medicine classes, but they have just on the basis of the your this initial basic concepts in this hemostasis and all, a few things they have asked to discuss, and they have exemplified hemophilia and purpura. Just remember blood clotting disorders, we had mentioned about thrombosis. Hemorrhage means, what is the meaning of hemorrhage? Means bleeding. So if clotting is weak, then it will lead to bleeding. If clotting is too strong, it will lead to thrombosis. What is thrombosis? We had mentioned yesterday. Just come back. Formation of a blood clot inside a blood vessel. Just simplify it as, if blood clotting is too strong, if blood clots inside blood vessels, we had mentioned of the Virchow's triad, which is the most important one here. Vessel wall injury, stasis or hemostasis are occurring. We are mentioning about hemostasis primary, secondary and all, but hypercoagulity will lead to thrombosis. Okay, hypercoagulity. So hypercoagulity, that is thrombosis, formation of blood clot within the blood vessel. So too strong clotting will lead to formation of blood clots within blood vessels, and if it is just for depiction. If it is like too weak, then it will cause bleeding. So like they are showing like a balance of the weight, like we the weight balance, they are showing it like that. So there should be a balance which we talked about. That's why blood does not clot inside the blood vessels, and why blood clots when it is required. After endothelial breach, what happens? So too strong thrombosis and too weak it is, bleeding will occur if the clotting factors are not coming into action. And if platelets itself cannot act, platelets themselves cannot act, even primary hemostasis will be affected. The arrest of bleeding, what we did in the practical part as bleeding time and clotting time. That bleeding, arrest of bleeding measures the bleeding time, or the actually the vice versa. Bleeding time estimates this arrest of bleeding, the time required for it. Clotting time estimates the formation of this fibrin thread, this fibrin. So increased susceptibility, this is about, so bleeding, increased susceptibility to bleeding, bleeding disorders. So bleeding disorders and clotting disorders. So bleeding disorders are mentioning this blood clotting is not happening adequately. So those are leading to bleeding disorders. So many causes are written, I don't think you have to worry about them now. We will read it about these things in medicine, so many difficult looking names. So one or two we will discuss, like von Willebrand disease will be related to the von Willebrand factor we have talked about, and hemophilia is due to, as far as you know of till now, I think it is due to the deficiency of factor 8, and there are so many other types of causes, so that they lead to increased susceptibility to bleeding. So those can be considered. You will read about them again, maybe not all of them at the MBBS level itself. So these things, there are so many diverse causes. Then someone goes for a medicine, that means postgraduate course in medicine, or even postdoctoral course in hematology. So there are so many causes, so many causes that has been classified, that are related but distinct, somewhat related but actually distinct causes. So we will talk about one or two of those. There are congenital causes, there are acquired causes. Acquired causes, see, these things can you can write just from common sense that decreased platelet counts or increased platelet decrease. What can be the causes of thrombocytopenia? Either formation is less, any, not only thrombocytopenia. What can be the causes of decreased RBCs? Either they are not being formed or due to some reason they are getting distracted. The spleen is, that means spleen has become hyperactive. Hypersplenism will lead to decrease in this, what the RBCs are destroyed, platelets are, so platelets are destroyed. So these will lead to this decrease in causes. So these can be written somewhat from your just common sense, common knowledge, that increased destruction or decreased formation or increased destruction both can lead to the decreased counts. Okay. So these are, there are various vascular problems. Liver diseases will obviously liver diseases will cause decrease in the clotting factors, right. So congenital causes, so many, just we will discuss just von Willebrand disease and hemophilia in short among them. So these are leading to increased bleeding, increased chances of bleeding. And what are hypercoagulous state? Again it is also called thrombophilia. Always the hypercoagulous state itself is called thrombophilia. Thrombosis is the formation of the clot within the blood vessel, but till one clot is blocking the blood vessel, we will not call it thrombosis, but it can be called thrombophilia, hypercoagulous state, which is due to maybe genetic or acquired disorders. Genetic means congenital or acquired disorders which are derived genetically, or acquired disorders. There are various causes for it, just one or two have been mentioned here. So we will mention one or two of them. You don't need the extensive list at all right now. It will confuse you. Don't go for writing all those extensively. So we will discuss one or two just for the basic concepts what are happening. So this is alteration in the hemostatic balance between blood fluidity and blood conversion. That is the definition. Again, that is also not required, just concepts are, just know the basic concepts. So thrombosis we have mentioned, it is occurring as a result of abnormal activation of the coagulation cascade leading to blood formation clot within the blood vessel. What is the difference? The solid mass formed is called the thrombus. Now what is the difference between thrombus and blood clot? Blood clot, what we are mentioning, what is occurring naturally to prevent this, prevent bleeding, loss of blood through this injury or through this wound. That is what is normally calling the blood clot, involves the clotting system, but thrombus can involve the formed elements of blood, like this blood is clotting within the blood vessel and forming an obstruction. Obstruction may involve some RBCs also. Whatever is there within the blood, that is within the purview of that, with that clot. So that is involves the wall of blood vessels, formed elements of blood, and of course the blood clotting factors, blood clotting system. So that is the difference between thrombus is abnormal, it is actually mostly harmful, and blood clotting mostly life saving. Why? Even if not life, it is actually for beneficial purpose. Blood clotting, what we are mentioning as blood clotting. What is thrombus? It is mostly, at most times it is harmful. It may also be life threatening at some times. So one of the bleeding disorders, not hypercoagulous state. Some authors are writing clotting disorder means hypercoagulous state. Bleeding disorder means where bleeding is, that means clotting factor is deficient. Just try to understand the difference. Bleeding disorder, some authors are mentioning bleeding and clotting disorders together. That means these are described one single heading and describing the disorders, and there is an extensive list what I mentioned. But some authors are saying clotting disorder will refer to those things which will cause this thrombosis and all. That means hypercoagulable state, So hemophilia is a type of bleeding disorder. It is occurring due to deficiency of clotting factor, but it is a bleeding disorder. That means it makes the body susceptible to bleeding, more and more bleeding. So that is normally what happens. Factor 8, whatever we have discussed, factor 8, von Willebrand factor comes into action. Factor 8 is there, platelet adhesion, activation, all these things normally happening. In hemophilia, lack of clotting factor A causes a weak platelet plug. Platelet plug means primary hemostasis. So hemophilia A is hampering the primary hemostasis itself. Deficiency of clotting factor itself, but as factor 8 is involved in formation of that platelet plug, initial stage, adhesion, activation, aggregation, right. So adhesion, activation, aggregation, that stage is hampered. So even the primary hemostasis is hampered, and also delayed fibrin clot, factor 8 is not there. So, at least this intrinsic system and eventually the common pathway system will be, factor 8 is required for forming that teenage complex which we talked of. So, it is being, clotting system is also hampered, but also primary hemostasis, because platelet plug formation also requires factor 8. But not only factor 8, factor 9 and 11 deficiencies can also lead to hemophilia and classified as hemophilia A, B, C. That's why this naming, if we come back to the naming, this one, antihemophilic factor A, antihemophilic factor B, antihemophilic factor C. So, 8 is antihemophilic factor A, 9 is antihemophilic factor B, and 11 is antihemophilic factor C. So, hemophilia A, B, C, these are congenital, and there is also classified one type of hemophilia is acquired hemophilia, which occurs again due to some reason or the other, due to some infections, due to some reason or the other, antibodies are formed against factor 8, mostly factor 8, autoimmune condition. We will read about immunity. Immunity is a part of the syllabus in physiology as well. You will again read about immunity in microbiology, in pathology, microbiology. Autoimmune conditions, we have not discussed immunity till now. It will be discussed along with this hematology portions only, and you can see the CBME, immunity is mentioned in your syllabus. So, autoimmune condition, factor 8, antibodies against factor 8, that is acquired, that is not congenital, that is acquired. Congenital, do you know the meaning of the term congenital? By birth. Congenital is what is got by birth, genetic predisposition, congenital hereditary disorders. So, factor 8 symptoms, you just, I have again not, there are slides on the specific symptoms, I have not brought it here just to simplify it, just variable symptoms, bleeding from under the skin, under the gums. There is a disease called scurvy due to deficiency of vitamin C, which includes some bleeding symptoms. So, any type of bleeding. In hemophilia, spontaneous joint bleeds can also occur, okay, seen in severe cases, and in severity of disease it is seen, it is less clinically severe than hemophilia A, but there are various symptoms. You just remember the names of the factors and just the basic underlying that clotting factors are deficient leading to bleeding disorder. Don't write clotting disorder, because some authors are thinking that clotting disorder should be classified or should be mentioned which leads to hypercoagulable state, not this bleeding states. Okay, so, hemophilia is a bleeding disorder due to deficiency of one or more clotting factors. It is hemophilia A, clotting factor 8, hemophilia B, clotting factor 9, hemophilia C, clotting factor 11, and acquired hemophilia is not due to deficiency of clotting factor, but it is due to formation of antibodies against one of these factors, but mostly factor, it is seen against mostly factor 8. If it is hemophilia A, this is again, there are some hemophilia A is X-linked, whatever will be sex-linked recessive. You have read about a bit of heredity in biology, school level biology. Sex-linked recessive means mostly males will be affected, females will be carrier. But this hemophilia C, it is seen, it is not sex-linked, it is autosomal recessive. Say again, men and women may be equally affected. So, another type is bleeding disorder is von Willebrand factor deficiency. There are so many those, forget the extensive list, von Willebrand factor deficiency. So, what does von Willebrand factor do? Everything we have discussed, platelet aggregation, first is adhesion. So, von Willebrand factor, it is derived from endothelial source, and where will be, and von Willebrand factor present in platelets where? In which type of granule? Light. There is nothing called light granules. We have mentioned of two types of granules in platelets, alpha and dense granules. So, the dense granules contains, again I had mentioned yesterday also, ADP, adenosine nucleotides and serotonin, except that most things are by, if not all, most things are in alpha granules. So, von Willebrand factor, factor 5 and fibrinogen, these are stored, these are formed by the liver, but diffused into the platelets and stored in the platelets. So, alpha granules also contains VWF. VWF also is derived from endothelium. So, VWF symptoms. So, symptoms are again any type of bleeding after someone does not know that this is not established in somebody, and we go for a surgery. So, increased chances of bleeding after surgery, even minor surgeries like a tooth procedure. Okay. So, two basic tests to diagnose whether there is a bleeding problem or not, bleeding issue or not, those are, so instead of these factors, these will require extensive laboratory testing to identify the deficiency of these factors. Basic tests done before every surgery nowadays, at least for the last few decades, what are they? What you did just in the practical classes in this week: bleeding time and clotting time. BT and CT are basic tests. They will not identify which clotting factor. CT will not, CT will not identify. Clotting time test won't identify which factor is deficient. But fibrin thread formation will be prolonged, and it can be just there is some clotting factor deficiency, that can be, this is a simple test, that there is some clotting factor deficiency. It won't identify the clotting factor. Those require more extensive testings. If there is one, everything is not discovered, not that all things has been discovered by science, is always evolving, but clotting time indicates only that some or other clotting factors are deficient. So, if von Willebrand factor is deficient, again this, it binds and carries factor 8 and all, it is a chemically, it is a glycoprotein. So, it helps in platelets adhesion. So, itself the first step of this primary hemostasis, that is platelet adhesion, is hampered, and it is related to bleeding symptoms. It has again various types, VWD, it has various types, forget about the types, but it is among the inherited bleeding disorders, it is the most common. What is most common? That is affecting 1% of population. 1% of population is actually, if you get is by number, it is huge. And actually these most literatures are, these are western, from western texts, most literatures. So, they are, I do not know which population they are talking about, but if you consider our country, and if you consider 1% population, what is that? How much is that? Like 1.5 crore, 150 crore, 15 crore, like 1.5 crore. So, 1% is not a very less number, it is actually a huge number. So, this is the most common inherited disorder, 1% population, but fortunately symptoms, it is the severity of symptoms is very less in most people. 1% of those 1% suffer from severity of symptoms, right? That is what has been seen. So, but 1%, affecting 1% of the total population is actually a huge number. Okay. So, it actually, VWF actually exists as a series of multimer. VWF multimers are formed in blood, and those are broken down by something called the, okay, we will come to it. VWF multimers are broken down by something called this enzyme, ADAM-TS13, ADAM-TS13. Okay. So, VWF multimers are exist, and it has been, again it has been seen in group O, it is not written over here. In non-group O patients, VWF levels are higher physiologically. VWF levels are lesser in group O, blood group O, we should call subjects or patients, whatever you call. Group O individuals have lesser VWF group. So, pathophysiology, again we mentioned the terms qualitative of quantitative in the practical classes. Quantitative means anything, platelets, quantitative decrease means decrease in number, qualitative decrease means number is okay, or even if higher, those are defective in not performing, not being able to perform their function due to some reason or the other. Say platelets are there, but the receptors are defective. So, how will they work? So, like that. Again, types of disease 1, 2, 3, okay. 2 again has classification, mostly this will be leading. Type 1 usually has mild symptoms, type 2 has mild to moderate symptoms, severe symptoms in type 3 it has been, and type 1 is due to less VWF levels, but type 2 is due to again qualitative defects. So, these are just some type. A little about something called purpura. Purpura, we had mentioned this term purpura while discussing platelets. Purpura is purple spots, it has come from purple spots under the skin, purple reddish or reddish spots under the skin. Purpura is a bleeding disorder because these purple or reddish spots under the skin are due to this bleeding under the skin. That means bleeding this under the capillaries under the skin. Some terms like petechia and ecchymosis are there, you will again come across in medicine. These are according to the size. Petechia are hemorrhages very minute size, less than 2 millimeter or less. 2 millimeter to 1 centimeter, they are called as purpura, and ecchymosis, same thing but bleeding under the skin, but ecchymosis more than 1 centimeter. It results from the extravasation of blood. Extravasation, blood is coming out of the blood vessels and it is under the capillaries of the skin. That is the condition of purpura. There are different types and causes. I am asking you to, just suggesting you to mention any extensive list as of now. Just this slide is for just to show you that it may be abnormality in primary and secondary hemostasis, and causes may be related to the endothelium. Disruption is vascular integrity, means endothelium breach due to some causes, trauma, infection, anything. Vasculitis, itis, wherever you find the terms itis, it is referring to inflammation. You don't know about inflammation right now. Inflammation will be discussed in detail in pathology. Okay, so vasculitis. So I am not asking you to go through the list. It is just for mentioning that it may be due to hemostasis problem or itself disruption in the structural or functional disruption in the vascular integrity itself, endothelium and all. So causes of purpura, causes of this bleeding under the skin. Two types which are very commonly mentioned in purpura are, one is ITP, idiopathic or immune. Purpura, thrombocytopenic purpura, and instead of the term thrombocytopenic purpura. So ITP is due to antibody coated platelets. Autoimmune disease, platelets are attacked by antibodies and they are destroyed by the spleen. That's why platelets are become less in number, that is a thrombocytopenia. Thrombocytopenia decrease in platelets due to antibodies, and thrombotic thrombocytopenia due to deficiency in that substance ADPase 13, which is not VWF multimers are broken down by ADPase 13, but if they stay as multimers, they themselves block along with RBCs, platelet dysfunction occurs, and they themselves along with platelets and RBCs block the blood vessel. Okay. So this is the physiology or pathology of, physiologically VWD multimers will break down. This is in case of thrombotic, it causes thrombosis, ADPase 13, these multimers along with platelets and RBCs are again trapped in the thrombus. This is thrombotic thrombocytopenic purpura, platelets are not being able to act. And in case of idiopathic, I can also be is termed as immune, as it is immune condition instead of idiopathic. Idiopathic means we should know the meanings of the terms. Don't memorize these terms without knowing the meaning. Idiopathic means unknown cause, and immune means something else, it is the autoimmune. So I is sometimes written as idiopathic, sometimes as immune. It is idiopathic thrombocytopenic purpura or immune thrombocytopenic purpura. There is something called HSP, a very mentioned disease, rare disease but mentioned disease, Henox-Conlan purpura. These are after the names of the persons who described them. So pathogenesis is immune system activated against vessel wall, endothelial wall. So if the immune system is activated endothelial wall, again bleeding, there is bleeding tendencies, though that is purpura occurs, Henox-Conlan purpura. In addition to it, there is, due to this immune complexes and all, it affects the kidney as well. Glomerulonephritis we will mention during renal physiology, but itis means inflammation, you will read about inflammation in pathology. For now, just concentrate on this term purpura, Henox-Conlan purpura. There is associated, there are kidney damage, liver damage, there is due to kidney damage, there is increased blood pressure, hypertension, increased blood pressure. There is joint pain due to deposition of immune complexes, that is called arthalgia. These will be discussed, I think, even if discussed, it will be discussed in medicine, but just for mentioning purpura, we are mentioning some types of purpura, 1 or 2 types. This is a hypercoagulable state, activated protein C is not there, okay, deficient. Okay, so factor 5 is, that is it, activated protein C does not allow excess activation of factor 5. So, it becomes a hypercoagulable state. Factor 5 Leiden, it is again after the name of somebody, factor 5 Leiden, it is a hypercoagulable state. What type of disorder? Bleeding or clotting? Clotting disorder. If we go according to those authors who are mentioning hypercoagulability as clotting disorder or clotting disorder as hypercoagulability, factor 5 Leiden is one of the hypercoagulable states where activated protein C is less, so that factor 5 is getting activated more than what is required normally. There is anti-phospholipid antibodies. It is again difficult to explain because platelet phospholipids are actually helping in clotting, but anti-phospholipid antibodies, what they are doing, they are in the endothelial cell, they are expression of adhesion molecules. Even if you leave that, all these are through monocytes and all, upregulation of tissue factor. Tissue factor we have talked about. So, tissue factor production is increased and it is becoming a hypercoagulable state. Expression of glycoprotein 2b3 and also platelet action is increased. So, anti-phospholipid antibodies is another cause of formation of a hypercoagulable state. Okay. And just last thing on this, not the last, there is an extensive list. Disseminated intravascular coagulation, DIC is a very common accepted. Intravascular coagulation, that means within the vascular system it is widespread. Disseminated means widespread. Within the vascular system this hypercoagulable state is occurring. This has causes, there are due to some underlying disorders, there are so many underlying disorders leading to DIC, but what that does is that systemic activation of coagulation due to enhanced fibrin congestion of platelets. So, see, just note that two paradoxical things are occurring due to disseminated intravascular convolution, due to some infection or some reason. What it does, excess fibration formation, firstly it is leading to a hypercoagulable state, but as platelets and clotting factors are getting more and more consumed, when they are becoming deficient, and later it is leading to bleeding, because now when stoppage of bleeding is required. So, in someone with DIC, if an injury occurs, then bleeding does not stop easily, because clotting factors and platelets are getting consumed within the body itself. So, this is looks paradoxical, but this is the reason. Due to some reason, due to some underlying disorder, platelets, clotting factors all are getting consumed within the body itself, causing intravascular coagulation. But if any actual injury occurs, then bleeding does not stop, because platelets and clotting factors are already used up. To understand it very simply, DIC is again an extensive topic. Okay. So, just to mention that what can happen through this, that just to mention the basic concepts of it and mentioning some of the conditions, but extensively, not very extensively, but somewhat detailed you will study in medicine, and then in, if you do a post graduation in medicine or a postdoctoral in hematology, then these will be discussed further, or you will have to know. Okay, so this brings us to the end of this hemostasis part. We will continue with some other topic in this hematology